I'm Dr. Leandro Fernandez, Director of the Laboratory of Advanced Sonography at Instituto Médico La Floresta in Caracas, Venezuela. In the next minutes, I will discuss on the topic Doppler in carotid arteries. This is a very important matter because, as you all know, atherosclerosis is a major issue in Western countries. By using ultrasound, we can assess the carotid arteries looking for the presence of this disease in these very important vessels. So let's start Doppler in carotid arteries. Advanced sonography of carotid arteries. Let's begin by defining advanced sonography. This is a term used to refer a group of techniques which we can include Doppler in all its modalities, three-dimensional ultrasound, harmonic ultrasound, contrast agents or echo enhancement, real-time compound ultrasound, which is related to CT scan, extended field of view ultrasound, speckle reduction image or extreme resolution imaging, and it's necessary an important technical support to perform this kind of technologies because we need proper equipment, and in somehow has become some kind of new specialty among sonographists and sonographers to be trained and to have the capability to perform, as I said, these techniques, advanced sonography. Applications of Doppler and sonography in carotid arteries. The main indication is to look for atherosclerotic lesions. The clinical manifestation of this disease are mainly the transitory ischemic attack or the established stroke. And sometimes these clinical symptoms can be the amaurosis fugax. Non-atherosclerotic lesions are less common, but there is a big list of these conditions as kinking, arteritis, aneurysms, AV fistulae, extrinsic compressions, thrombosis, and others. Another very important indication is the measurement of the Intima-media. It's very important to determine the Intima-media thickening, which is very important in different medical specialties as cardiology, internal medicine, neurology, endocrinology, and many others, because it not only represents the presence or not of atherosclerotic disease, but also inflammatory diseases. So the measurement of these specific segments of the arterial walls are very, very important. Study protocol for performing carotid ultrasound. First of all, we must start with the anatomical position. Normally, our patient is in supine position with a mild extension of the neck. Sometimes it's good to rotate it, and a slight rotation to the left or to the right part of the neck. The transducers to be used are transducers convex or linear, it doesn't matter, but the important factor here is the frequency of the transducers. We need to use frequencies higher of 0.5 megahertz. As higher your frequency, better you can obtain better images because of the resolution of the system. The approach could be anterior or posterior to the sternocleidomastoidal muscle. We recommend the use of anterior approach in young patients. We can obtain a very well depiction of the vessels. In elderly patients, the posterior approach can offer better depiction of the carotid arteries. Those are the vascular segments that can be assessed by using Doppler or ultrasound, advanced techniques of ultrasound. This is the common carotid artery, and we can observe the common artery in the proximal medial and distal portions. And it's very important to evaluate the three segments of the internal carotid artery: the bulb, this is the proximal segment, the medial and the distal segments. Also, it's important to evaluate the external carotid artery, and we can recognize or differentiate both arteries by observing this first bifurcation here in the external carotid artery. This artery corresponds to the superior thyroidal artery. In this slide here, we can observe how we can obtain or the orientation of the image in our screen when we do or perform the anterior or the posterior approach. When we do the anterior approach, first, the first vessel that can be observed is the external carotid artery, and the second vessel will be the internal carotid artery. By using the posterior approach, the first vessel to be observed will be the internal carotid artery here, and the second vessel will be the external carotid artery. So, anterior approach, the first vessel will be the external, and the second vessel will be the internal carotid artery. With posterior approach, the internal first, and the external has a second vessel here. And again here the bifurcation, this is the superior thyroidal artery. The study protocol that we use in our laboratory is this one here. We start with B mode. We always apply or use the real-time compound ultrasound because it offers a better resolution and a better image. Then we go to Doppler. We start with color Doppler, then we go to power Doppler, then spectral analysis. We are very interested in three-dimensional ultrasound, so we perform vascular 3D ultrasound, and then we go to surface and multiplanar three-dimensional ultrasound. But really, this is a matter of research at this moment. We don't have a very clear clinical application until this moment, but we always do it, and we compare our results with the conventional ultrasound. But in any vascular lab, those are the techniques used: B mode, real-time Doppler, with color, power, and spectral analysis. We start with evaluation of the internal, the Intima-media thickness. In this case, we can see here the Intima-media. It is represented by this hyperechogenic line here. This is the intima. This hypoechogenic line, this is the media. And again, we have another hyperechogenic line or interface corresponding to the adventitia. So in this case, we mark or place our markers or calipers here in order to determine the thickness of these vascular structures. The normal measurements of the Intima-media is less than 0.9 millimeters. When you have an Intima-media of 0.9 millimeters, it can be considered abnormal. You can see that it is enlarged in those cases. By using different techniques, in this case we are using some kind of color here, a color display in sepia, and using also extreme resolution and compound ultrasound, we can obtain a better definition, but always with the value under 0.9 millimeters to be considered normal. In this case, we have an Intima-media hyperplasia of 1.7 millimeters here, and we can even see here just a small spot of hyperechogenic area here corresponding to a fibrotic area in this enlarged Intima-media. By using color Doppler, we can obtain a better definition. Of course, we can see it by using only B mode, but when we combine the two techniques, Doppler and B mode, we can observe here in this case and a uniform hypoechogenic area of 1.9 millimeters. This is an Intima-media enlarged Intima-media. And in this case, it's not only hyperplasia, but it's almost a plaque here in the anterior wall of the common carotid artery, with an extension of 3.3 millimeters here, and 2.8 millimeters also. It's important, the place where you make the measurements of the Intima-media. These measurements must be done 1 centimeter before the carotid bifurcation. It is important to all the labs and everyone makes the measurements in the same at the same place, because we can make a proper follow-up of these cases, of these patients, in order to see the progression of the disease or, for example, the response to medical treatment. Of course, if we see the presence of disease in another places of the vessel, it's important to report it. But the measurements must be done in this centimeter before the bifurcation. And it's important to explain that information, or to write this information in our reports. This is an example of Intima-media hyperplasia and fibrosis. We have 3 fibrotic plaques here, very tiny, very small, and you can see here that we have a thickening of only 0.9 millimeters. Inside this thickening, we can observe a well-defined 3 structures or 3 plaques, because we have these hyperechogenic areas here without acoustic shadowing. We will explain that with more details in the second part of the lecture. Another case with Intima-media hyperplasia and calcification. We observe the hyperechogenic area with acoustic shadow here, with acoustic shadowing. By combining the color Doppler, again, we can obtain a better definition. This is color Doppler, and this is the normal Intima-media. And this is the representation of the internal carotid artery in the proximal segment, the bulb. In the bulb, we can observe, by using color Doppler, this bidirectional color flow. It is represented because we have a helical flow movement in this vascular segment. So the flow goes up and goes down, through the bulb, and this is the reason because the color Doppler represents these 2 codifications, up and down. Here we can observe the color bar, and this is the reason because we can obtain this kind of image, and this is a normal image that we have to look for. When we lost this image, something wrong is happening in the bulb. We must, in that case, look for a plaque or any condition that is altering the normal hemodynamic of the bulb. Then we go to power Doppler, and the power Doppler in this case is representing only the presence of flow, not representing the direction of flow. And with this technique, with power Doppler, we can obtain a better depiction of the flow inside the vessel. Now we have the distal portion of the common carotid artery, we have here the external carotid artery, and here we have the bulb, the proximal portion of the internal carotid artery, and in fact we are observing here a plaque. This is a soft plaque that we can also name fibrolipidic plaque. Those characteristics will be presented in the second part of the lecture. Spectral analysis provides a very characteristic wave behavior, and it's very useful because by looking for alterations in these waves, we can make a proper diagnostic. This is the normal spectral wave of the common carotid artery. The spectral analysis shows high resistance, and we say that is high, the resistance index is high, when the value is equal or higher to 0.75. The wave can be dicrotic, and the wave always will have the spectral window empty. The wave can be mono, bi, or three-phasic. In this case, we are observing a wave, a monophasic wave, but with a dicrotic behavior. But this is normal. And the peak systolic velocity is always less than 125 centimeters per second. The external carotid artery presents a very similar spectral analysis to the common carotid arteries. If you compare both spectral analysis or spectral wave, both are very similar. Both present dicrotic portions. Both are monophasic, but can be, I insist, bi or three-phasic. And the velocity is always less than 125 centimeters per second. So both waves are definitely similar. The internal carotid artery has his own characteristics also. The spectral wave is of low resistance. It means that the resistance index is less than 0.75. The wave will be always monophasic. The measurements are done in the mid portion and the distal portion, because if you place the sample volume here in the bulb, you will get a bidirectional spectral wave, because, as I explained before, the flow in this portion is helical. So we have a monophasic spectral wave with empty window. It's quite important to see the spectral window empty in the internal carotid artery. If you find some echoes inside, it means that it represents turbulence. And if you find turbulence, it means that or you have an stenotic plaque, or you have any anatomical condition as a kinking, for example. But this characteristic of turbulence reflects abnormal condition. So for a normal internal carotid artery, you must find an empty window. And the peak systolic velocity is always less than 100 centimeters per second in these vessels. With these characteristics of the spectral wave, these normal characteristics, we can, if we find some alteration, we can make a proper hemodynamic diagnostic of stenosis. We will see these abnormal characteristics in the second part of our lecture. There is a good correlation between the pathologic anatomy and the ultrasound findings of the plaques in carotid arteries. The plaques can be soft, fibrotic, calcified, and mixed or complex plaques when we have any combinations of these soft, fibrotic, or calcified characteristics. And we also have complicated plaques when we find hemorrhage or ulcerations or even necrosis inside the plaque. Those are the sonographic characteristics of the plaques. A soft plaque looks with low to intermediate amplitude echoes. The fibrotic plaque shows high amplitude echoes without acoustic shadow, and the calcified plaque present high amplitude echoes with posterior shadow. This is very important because we can make the differentiation between these two kind of plaques. And this is important because the embologenic potential of the fibrotic plaques is different of the calcified plaques. The mixed plaques present a combination of signs. So we can have a plaque with soft, with calcified portions, or a fibrotic plaque with soft portions, and any kind of combination among these three conditions. The complicated plaques present hemorrhage, ulceration, and necrosis. And the sonographic characteristics are heterogeneous, anechoic focal lesions, and irregular surface. The stenosis caused by these plaques can be observed mainly in the bifurcation, in the origin of the internal carotid artery, or in the initial segment of external carotid artery. But in fact, the condition can be observed in any place of the carotid arteries, not only in the internal or external, but also in the common carotid artery. So it's necessary to perform a very well detailed test in order to try to find these sonographic signs. This is an example of a soft plaque. We here observe hypoechogenic structure. It means that the constitution, the components of the plaques are soft, high potential of embolism here. Pay attention with that. And we are observing that the plaque grows not only to the external portion, to the adventitia, and the growing will stop depending on the compliance of the adventitia of the carotid artery, and then the plaque will start to grow to inside the lumen. So it's very important to determine the size of the plaque, the surface of the plaque, and by using color Doppler we can observe how the flow is accelerated in this portion, and it is represented with this aliasing phenomenon. Sometimes the soft plaque is so hypoechogenic that we cannot observe the plaque by using just B mode. Activating the color Doppler, now this plaque appears very clearly here, but without the color Doppler it is almost impossible to detect the plaque. So it's very important to use all the technology that we can have in our system, in our equipment, with not only color Doppler but also power Doppler in order to obtain a better depiction of the surface of the plaque. Again, in only B mode, no plaque is seen here, and then we color Doppler, and then we power Doppler. Power Doppler offers a very clear detail of the surface of the plaque in this case. This is a soft plaque. Another example of hidden plaque. In this case, we cannot observe the plaque here in the posterior wall of the bulb. Not only the bulb, the proximal segment, but only the medial segment is affected by the plaque here in this internal carotid artery. We can detect just a signal here, a very small signal here, small echoes corresponding to a fibrotic point in this side of the plaque. By using the color Doppler, we can observe that we have a soft plaque in this portion of the internal carotid artery, and also here in the anterior wall of the external carotid artery. Another example, this is a soft plaque. The soft plaque is also called fibrolipidic plaque. Both expressions can be used. Here with B mode, then the use of color Doppler, here with power Doppler. If we place our ultrasonic beam in this portion, in this very specific portion, and go from longitudinal to transversal, this is the kind of image that we can obtain. And here we are observing how the plaque takes almost all the lumen of the vessel with only this residual lumen. Only here we have patency of the flow. In this segment here, this is the transversal view. And this is very important because we have to determine the grade of obstruction, the grade of stenosis, and I will discuss how can we perform this estimation. Those are fibrotic plaques, hyperechogenic echoes without acoustic shadowing. This is the internal carotid artery, this is the bulb, this is the external carotid arteries, this is a posterior approach. And now, by using color Doppler, we can observe the surface. But in this case, the color Doppler is hidden the lesions. So we have to use, I said it again, all the techniques: B mode, color Doppler, power Doppler, in order to make a proper assessment of the vessel. An example of calcified plaque. Here we have a hyperechogenic plaque and acoustic shadow. And here the B mode shows the flow on the bulb and the median portion or segment of the internal carotid artery. Those are mixed atheromatous plaques, better observed by using color Doppler. We have here soft component and we have here fibrotic component. And here we have an example of a complex plaque. This is our complicated plaque. This is an ulcerated plaque. In this portion here we have an ulcer, we have soft plaque, and here we have a calcified plaque. This is a complex plaque in the anterior wall of this is the common artery. Almost, this is the terminal or the distal portion of the common carotid artery. But this is very dangerous because it is ulcerated, and ulcerated plaques have the highest emboligenic potential. Here we are observing the same plaque, but now using the color Doppler. So this is the ulcer is very evident or very apparent by using both techniques. Another complex plaque. This is the distal portion of the common carotid artery. This is the bulb, the proximal portion of the internal carotid artery. Here we can observe an irregular surface here. This is a complicated plaque with anechoic images inside the plaque. They correspond to necrosis or maybe hemorrhage inside the plaque, internal hemorrhage inside the plaque. And this is the residual lumen here, only this portion here. So, the emboligenic potential of the plaques: soft, high potential; fibrotic, medium potential; calcified, low potential; and complicated plaques, they have very high potential to produce emboli. Internal carotid artery stenosis quantification. It is very important to quantify the grade of stenosis because with this data, or with these values, we will take clinical decisions if our patients will go to medical treatment or surgical treatment, in endovascular or surgical treatment of the type of endarterectomy. There are two techniques to determine the internal carotid artery stenosis. Both were published many years ago, at the beginnings of the 90s, 92, 93, the European Carotid Study Trial and the North American Study Carotid Endarterectomy Trial. The North American method takes the residual lumen and takes the normal distal lumen of the vessel and make a relationship by applying this formula here, B minus A divided by B. And the European study takes or make all the measurements in the place of the plaque and in the place where the residual lumen is. Take so this diameter here, diameter C, diameter A, so C minus A divided by C. The problem here is sometimes when you use the NASET method, you can underestimate the grade of stenosis. And sometimes when you use the European method, you can overestimate the grade of the stenosis. Let's see some examples here. This is a soft plaque, an important soft plaque, located in the posterior wall of the bulb. This is the North American method. Here is the residual lumen. This is the distal lumen of the vessel, the normal distal lumen of the vessel. And here the computer offered the formula. It's not necessary that we calculate them. The computer offers the results when you place the calipers. And it says here 37%. But maybe if you make the measurements here, you can say that it's more than 50%. This is a non-significant stenosis, and more than 50% it's a significant stenosis. And here we have an example with the European method. Here, making all the measurements at the level of the stenosis and the level of the plaque. So we have the residual lumen here, we have the diameter of the vessel here, and the computer says 65% of stenosis. And we have another method to do. We can make measurements in transversal view. In this case, we have the adventitia here, then we have the plaque, and here we have the residual lumen better observed by using the color Doppler, power Doppler. And it says here that we have a reduction of 56%, again, more than 50%. So it says that this is a significant reduction of the vessel. Which method are we going to use? Well, we need to make a hemodynamic correlation between the B mode in transversal on longitudinal and the Doppler analysis, the spectral analysis. This paper was published in 2003, and this is a result of a consensus of experts in the matter of carotid artery. And I think this is a very interesting and a very important material. Many laboratories are using this method all around the world. This is the method, or this is the rules in somehow that we use in our laboratory. Those are the velocity criteria recommended by the panel of experts. We can say that we have a normal carotid artery when there is no intima-media thickening or plaques, and the velocity is less than 125 centimeters per second. This is normal. If we see any plaques or any intima-media thickening, but the velocity is less than 125 centimeters per second, so we have a stenosis, a non-significant stenosis, and less than 50%. This is a mild stenosis. When we have the intima-media alterations and when we have the plaques and the velocity reaches 125 to 230 centimeters per second, so this is a moderate stenosis, significant but moderate, in the range of 50 to 69%. When the peak velocity, the systolic peak velocity is 230 or more, in this case we have a severe stenosis, internal carotid artery stenosis, more or equal to 70%. We have another condition, more condition here. If the visible plaque and we are saving lumen narrowing, we can use the expression to near occlusion. But if the lumen is really markedly narrowed, in this case we use the expression near occlusion. And we have a total occlusion, 100% of occlusion, when there is no detectable patent lumen at grid scale ultrasound and no flow at spectral power and color Doppler ultrasound. Very important to make these measurements, the angle of the sample volume must be at 60 degrees. This is an example of the behavior of the spectral wave. In this case, we have here a very important stenosis. This is the same patient of the complicated plaque that I showed you before with the internal area of necrosis. And here we have aliasing in color Doppler. We placed right here the sample volume, and we have a systolic peak velocity of 350 centimeters per second. So it corresponds to a severe stenosis more than 70%. The velocimetry is very important, but attention, it's very useful, and it's useful when our patient has a normal left ventricular ejection fraction. But some patients with myocardiopathy or valvular stenosis, these patients will not reach that velocities I mentioned before because the ventricular ejection fraction. And in this case, we must observe the spectrum, and we can compare the hemodynamics of the vessel itself. So we can observe, or it's necessary to observe or make the measurements in the previous segments and observe the velocity then in the area of the stenosis. If the systolic peak velocity doubles the previous velocity of the end diastolic velocity, makes 2.5 times, this is a severe stenosis. And we can say that we have a critical stenosis when the systolic peak reach 4 times the previous velocity, or the end of diastole reach 5.5 times. And here we have an example. In this case, the previous velocity is only 48.7 centimeters per second. But exactly in the area of the stenosis, the velocity reaches here 477%, so 10 times the previous velocity. This is a critical internal carotid artery stenosis. This is the string signs. This is the expression that some authors use to a very, very reduced lumen of the vessel. We only can detect just a small amount of Doppler signal. Sometimes we can better observe this severe obstruction with power Doppler. We only have just a string of flow in this place. This is the internal carotid arteries string sign. In some cases, we can observe a total occlusion of the vessel. There is an important atheroma here, totally occluding the lumen of the vessel with no color Doppler signal, again, no power Doppler signal. It's absolutely silent on 3D, and here no spectral analysis can be obtained because the total occlusion, 100%. In our laboratory, we perform first the Doppler study, and we make the diagnosis or the diagnostic of occlusion on the grade of stenosis only by Doppler. And then our patient goes to arteriography, not for diagnostic, but to make an invasive procedure, in this case, to stent placing. And here we have the stent placed on the area of the stenosis. This is the previous to stenting, and here after placing the stent. Again, the patient with the stenosis, I showed you before, 350, day 30, and day 31 or 31st. The next day, the problem is resolved by placing a stent. This is the posterior or the control Doppler, and the velocity, previous to the procedure was 350, now is 96 centimeters per second. Doppler and angiography. Let's compare the sensitivity and the specificity. When we used 130 centimeters per second as cutoff point to estimate the grade of stenosis 50%, the sensitivity is 98%, the specificity 88%, and by using 200 centimeters per second to estimate the grade of stenosis equal or higher than 70%, the sensitivity is 90% and the specificity is 94%. We are using 125 and our practice according to the panel of experts, and we are using here 230. If we increase this number, so our sensitivity will be higher. In conclusion, Intima-media measurement is such important and has blood pressure values and cholesterol levels in order to estimate clinical and subclinical atherosclerosis. And the Intima-media measurement provides information of treatment response. For example, when the patient is undergoing treatment with statins. Finally, carotid sonography is a unique imaging method for the investigation of carotid abnormalities, non-invasive, accurate, and cost-effective. It provides morphologic and functional information. It is increasingly becoming the first and often the sole imaging study before endarterectomy, whereas costly and invasive procedures are reserved for special cases. I hope this information will be useful for your practice. Thank you for your kind attention.